Good morning, everyone. 6 o'clock, so we'll go ahead and get started. Yusef, one of the spine fellows, is going to be talking about intraoperative neuromonitoring this morning. So the purpose of neuromonitoring is it's really the only way to interrogate the nervous system integrity under anesthesia, I guess, with the exception of visualizing direct neural injury. But in the absence of that, and hopefully in the absence of that, this is really kind of the best modality that we have to see how nerves and spinal cord are functioning. And so the goal of it is to really decrease the prevalence of iatrogenic neurologic sequelae. And so this hopefully improves surgical precision, detects impending injury, and with ability to warn the surgeon, and then prevent or reduce incidence of severity of adverse patient outcomes. And additionally, for medical legal purposes, there is a function to protect the surgeon and hospital from spurious litigation. So it's not this last point I put a little asterisk by just because neuromonitoring still isn't quite perfect, but still it can be in the armamentarium for this. And so a couple of definitions, I think, before proceeding. So amplitude, which is typically measured in microvolts, is the strength of a signal, and it's measured from the baseline to a peak or a trough for any reference point to another point in time. Latency is measured in milliseconds, and it's usually a time interval. It's essentially just the speed of the signal, so the time it takes from a stimulus to being recorded or going to its intended destination. Baselines are patient-specific recordings of pathways prior to positioning or surgical intervention, obviously very important when we're dealing with patients whose baselines may not be perfect. And then a significant change, which is a typical change seen with the neurophysiologic recordings that have been shown to correlate well with intraoperative injury. We'll talk about this in a little greater detail, but here's a chart just kind of highlighting the different types of significant changes per the different modalities. And so for somatosensory evoked potential, or SSEPs, typically this is a drop in amplitude less than 50%, latency greater than 10%. For motor evoked potential, or MEPs, you're thinking about increasing voltage threshold from 50 to 100 volts. And then for pedicle screw stimulation, it's quoted between 7 and 10, but studies have shown that 8 is kind of the cutoff, and talk about that a little bit more too. Now, back to our neuroanatomy, which you love, especially Nikita, talking about the spinal cord and the relevant tracts within the spinal cord. And so on the left, obviously, are the motor pathways. These include the lateral cortical spinal tracts, which are the main voluntary, as well as the ventral cortical spinal tract, which is also part of the motor pathway. And if you remember, the central, more medial portion of the spinal cord can tend to control the upper extremity, with the lateral controlling more of the lower extremity. And so that's why in cervical cord syndrome, typically uppers are affected more than lowers. On the right, in the gray, you can see the sensory pathways, which include the dorsal columns, which are responsible for deep touch, proprioception, and vibratory sense, the lateral spinothalamic tract, which is pain and temp, and then the ventral spinothalamic tract, which is light touch. All right, so let's talk about the multimodal approach to neuromonitoring. And so there is redundancy built in the system. I think this is exceedingly important, again, given the advantages and disadvantages that are inherent with the different types of modalities within neuromonitoring. And so you need to have redundancy in order to hopefully make sure that you're catching all potential neurologic injury. And so this can be achieved through active and passive means. So in regards to active, we have our somatosensory evoked potentials, our motor evoked potentials, and then our triggered EMGs, which is typically used to test maybe like pedicle screws or direct stimulation of something that we think is a nerve or not. And then we have passive continuous recordings, which include EMG or electromyography, and then electroencephalography, which is EEG. In regards to the different monitoring types, they kind of correlate to different, obviously, parts of the neuroanatomy within the spinal cord. And so your motor evoked potentials are going to look at the corticospinal tracts. The SSEPs are going to look more at the dorsal sensory spinal tracts. And then your spontaneous EMGs and dermatomal evoked potentials usually are focusing within one specific motor or sensory nerve root. So what's an evoked potential? It's pretty much self-explanatory. Essentially, you start with delivering a stimulus at a certain point and then recording an electrical snapshot at some point in time at a distant location along the pathway. And so for MEPs, you're going to start by stimulating in the brain, and recording the lower extremities or upper extremities, recording kind of that muscle output or EMG output. And then when it comes to SSEPs, you're going to start in the upper extremities or peripheral nerve, and then record up in the brain. And so that's usually how we get that information. So let's kind of transition a little bit and start talking about somatosensory evoked potentials. And so, as I mentioned, these are a surrogate for the dorsal column pathway, which is supplied by the posterior spinal artery. And we'll talk about that anatomy a little bit more. So the pathway that this takes is stimulation of a peripheral nerve. The SIG travels up the dorsal column, crosses to the contralateral side, if you can remember, at the cervical medullary junction, synapses in the thalamus, and then is detected, or that sensory input is into the primary sensory cortex. So the nice advantage of this modality is that there's an established alarm. We have a certain cutoff that we are looking for, the neurophysiologists are looking for intraoperatively, that they can, put an alarm for that. If this value breaches X, Y, and Z, then we know that it's problematic. The other nice thing is that you can use it with paralytics, contrary to stimulated EMG or motor evoked potentials. If a patient has paralytics on board, then unfortunately you can use SSEPs. But also some, several disadvantages, and we'll kind of talk a little bit more about this in the literature as well. It's very sensitive to anesthetics. Anesthetics can really cause signals to fade that are not due to anything surgically, so something to be very cautious of. Average potentials take time to calculate, essentially, and that can be in the realm of 5, 10, even upwards of 30 minutes, as some of the studies have shown. So maybe a delayed response in some changes. And then there's documented false positives, false negatives, and again, we're not really covering anything in regards to the motor function. So again, just looking at the distribution of the blood supply of the spinal cord, which you can see here, most of the 1/3 of the cord in general, and the posterior 1/3 is mainly supplied by the posterior spinal artery. And as you can see, the anterior 2/3, including the important motor tracts, are typically covered by the anterior spinal artery. So again, SSEPs may not detect ischemic injury from the anterior spinal artery. So the typical setup for SSEPs intraoperatively are, we're looking at the upper extremity for a stimulus location and the lower extremity. But in the upper extremity, typically we're targeting either median or the ulnar nerve. The ulnar nerve exits a little bit lower, so maybe you get a more breadth of an assessment. And then you have, for the lower extremity, the common perineal or the posterior tibial nerve. And then we're recording this signal from the head scalp. You can technically record from the spine, also upstream, or the brachial plexus. But obviously, in our scenarios, we typically do it from the head and the scalp. The cutoffs for kind of that significant change that I mentioned, again, are loss of amplitude greater than 50% or increased latency greater than 10%. So just again, just talking about this concept of coherent averaging, which is basically you have a bunch of different stimuli kind of concurrently, and some of them could be caused by noise. Some of them, are maybe disrupted in regards to its signal quality. And what happens is that you take all of these stimuli, you take all these recordings at once, and you kind of average them into one general recording. So you can kind of see at the bottom that this is the actual average, and this is kind of the change that we're seeing when you're averaging all of those stimuli. But the problem, like I said, is that it can take several minutes to change following an acute insult. In fact, this was a pretty hallmark paper by Albert et al. From Jeff back in 2004, looking at the comparison between transcranial electric motor and somatosensory evoked potentials during cervical spine surgery. And so they found that SSEPs can lag MEPs by up to 33 minutes, which is pretty astonishing. No patients had SSEP changes in the absence of MEPs, so those kind of tracked well, and therefore they said that both the MEPs and the SSEPs were 100% specific, but where it was problematic was in its sensitivity, so ruling things in. So it was only 25% sensitive, unfortunately, at least in this study of about 460 patients. This is another article that basically says that, again, kind of this idea that SSEPs unfortunately are not a perfect modality. In their series, they had 6 patients with postoperative neurologic deficits. despite unchanged SSEPs during intraoperative monitoring. So you can already see a pattern that, these are great in picking up the things that we want, but unfortunately, it's not all encompassing in terms of what we ideally would want it to do. And so that again speaks to the multimodal approach that we typically take. All right, let's move on to transcranial motor evoked potentials. And so again, this is stimulating the motor cortex and then seeing the muscle response distally. So we start typically through a transcranial signal, either electric or magnetic, down the cortical spinal tracts along the peripheral nerves to the neuromuscular junction, and then we see the response in the muscle. As I mentioned, again, we're covering the anterior cortical spinal tracts, and you can technically measure it in the epidural space. We typically don't see that in our procedures, but in some of the intramedullary cases, they will do that to see kind of where the signals are going and to safely dissect the spinal cord. Advantages are it's comprehensive of the motor tract, and it's very sensitive and specific. The problem is that you can't use it with paralytics. It has narrow anesthetic demands, even though you can use it with anesthesia, it's still relatively sensitive. The alarm criteria tend to be a little bit more, I think, subjective. There isn't a kind of agreed upon consensus for a cutoff in terms of what's significant. And then it does require invasive intermittent stimulation. So, you might see patients jump time to time during the cases. All right, so in terms of the stimulus location, as I mentioned, you're going through the scalp via the into the primary motor cortex, and then you're either reading in the upper or lower extremities, or you can do it in the spinal cord. So touching a little bit more about the warning criteria, there unfortunately isn't a single universal warning criteria. There's a couple of different techniques and that you may hear about. I think typically we here probably employ the threshold technique, which is a myogenic response in amplitude, 65% below baseline, or a greater than 100 volt increase without recovery of responsive amplitude. You can also do the all amplitude technique, which increases the stimulus to maximum as long as the amplitude at baseline of response is maintained, or an all or nothing technique, which again, you can increase the stimulus to maximum, and a significant decrease in amplitude is allowable as long as its reproducible response remains recordable. And so, like I said, we typically aim, I think, for the threshold technique. This is just an example of what some of the neurophysiologists will see intraoperatively in terms of what may happen when you're having a change from baseline alone, and a little hard to see, but if you look here, this is looking at the left L4 and S1 via the tibia and the adductor hallucis. Green represents like the current reading, and then red actually represents the baseline. So we see that we're trending away from baseline in regards to the amplitude of this in this case. All right, so talking about the literature in regards to MEPs, this article from 2020 looked at the utility in posterior lumbosacral spine procedures, and they found that MEPs were highly specific and sensitive compared to both EMGs and SSEPs. All nerve root injuries had unresolved MEP alerts at the time of closures, so exceedingly sensitive and specific. And the diagnostic accuracy of MEP root dysfunction supports the inclusion of this modality during routine posterior extradural lumbosacral procedures. Now, I think you can probably take that with a grain of salt. There are probably cases that are going to be more problematic and higher risk compared to others. Like a simple decompression probably doesn't always warrant neuromonitoring, but again, something to be aware of if you're concerned about anything, whether anatomy is a little bit different or you're partaking in a higher risk operation. Definitely worthwhile to have MEPs on board. This next article from 2019 looked at the reliability to predict dorsiflexion injuries in deformity surgery. And so they concluded that the use of MEP amplitude changes were both sensitive and specific to detect new postoperative injury. And it's important to monitor two myotomes, which was found to be superior than just to monitor a single myotome in this series. Now, talking a little bit about electromyography, these are helpful to monitor the integrity of specific spinal nerve roots. And so at baseline, normal muscle and nerve are electrically quiet. when you get spontaneous firing, such as you might see in an image like this may implicate nerve injury and or nerve irritation. So we've all been in cases where we see, C6 on the left is firing kind of when you're picking in a nerve frame, and this is kind of what they're talking about here is this EMG activity. The advantage is that you can get pretty instantaneous feedback. It's continuous, it's passive. It could be somewhat prognostic, especially if you're working around the nerve root and irritating it. The nerve physiologist can, just let us know that that's happening. And it's minimally invasive, but there aren't really any specific guidelines. It's subjective criteria in regards to the alarm levels, and then you can't use it with paralytics, and it's not as comprehensive as MAPs. So you do have spontaneous versus triggered EMG. Spontaneous is, like I said, passively throughout the case. Triggered is a time-locked EMG, and typically this is used for pedicle screw stimulation or when seeing if a nerve is some viability or is present in the area, surgical area. All right. So this is a pretty big paper out of WashU. This is from, I think, 2007. Lanky and Dr. Bridwell kind of looked at the use of triggered EMG in detecting pedicle screw malposition in the lumbar spine. And they looked at just under 5,000 screws and basically found that if the EMG was greater than 8 milliamps, then there was a 0.31% chance of a medial breach. Again, and that follows the rules of physics that we may have all learned in high school or in college, that current flows through the path of least resistance. And so cortical bone tends to be high resistance. And so its path to the nerve root can depolarize the nerve at a lower level. And so, again, you can see the values here that they had from their study that, basically less than 8, you had a pretty high chance. And when you get down to about 3 milliamps, you have almost 100% chance of a medial breach. Whereas if you're above 8, then you are more than likely to be safe. This was a systematic review, I believe, a meta-analysis that looked at the same thing. And again, they found that the 8 milliamps was the most clinically useful threshold, particularly in the lumbar spine, with a relatively high sensitivity and specificity. This is looking at the clinical implications of triggered EMG. This is from GSJ in 2021, and they found that triggered EMG alarm thresholds are specific but weakly sensitive for new post-op neurodeficits. But patients with neurologic deficits were more than 10 times likely to have lumbar pedicle screw stimulated at a low threshold. So again, the clinical implications are still warranted, but nonetheless can give you information about malposition of screws. Let's talk about the lateral approach, because this is something that, when I first came in here, that I was a little confused about, and I think it's important to talk about since we do a fair number of these nonetheless. So the utility of these different modalities within, the lateral approach, let's call it. So EMG has low specificity. It can't directly detect nerve compression, so it can't tell you that you're crunching a nerve under the retractor, and unfortunately cannot reliably monitor sensory specific nerves. But you can use direct EMG, which we typically use in our cases with our attendings here, that we direct EMG areas to determine the proximity of the plexus within the psoas. And so again, we want to see typically that all the stuff is behind us or posterior. MEPs may accurately monitor peripheral nerves at the plexus, which innervate the quadriceps muscle. But again, this is limited in the use by anesthetic and paralytic options. And then SSEPs for the high lumbar sacral plexus, you can typically monitor the saphenous, and in the low lumbar plexus, you can do the posterior tibial or the perineal nerve. But there really isn't any consensus kind of between this stuff, but again, can be useful when performing direct laterals. This is looking at combined motor and sensory intraoperative monitoring for cervical spondylotic myelopathy. And so these will be a couple of articles in the literature looking at the utility and whether or not it is useful, I guess, in these types of procedures, especially when it comes to cervical spine. And so this series looked at 540 patients, and they found that the overall incidence of alerts was 1.3%, which were in fact all false positives. There was no clinical neurologic deterioration post-operatively. But there were fortunately no false negative alerts. And so they determined that this was 0% sensitive, but 98.7% specific. And so they questioned the utility within, ACDFs and whether or not this really was important to have, or just in their series, it just added setup time and cost. And I think this was a similar study that looked at a nationwide database. And they looked at 140,000 ACDFs, and of which 7% had intraoperative neuromonitoring, and no significant association between neurologic injury and intraoperative monitoring. In fact, neurologic injury was more correlated with age and multi-level fusion, non-elective admission, and a greater Charleston comorbidity index. And so they just found basically that the only significant difference between using monitoring and not was an additional almost $7,000 in hospital charges. This was a kind of similar study that, like I mentioned, reiterated the above stuff, but I'll kind of skip over it for now. Okay, so the use in spinal deformity surgery, and I think this is important. So this was a retrospective review. They looked at 176 patients that had both SSEPs and MEPs. They found that even in this series, the SSEPs lagged by about 15 minutes behind MEPs when both subsequently had changes. And they found better sensitivity and specificity when using both in concert. And the risk factors for having intraoperative neuromonitoring changes that they found were, the use of osteotomies, preoperative kyphosis, and Cobb angles greater than 90 degrees. So already higher risk procedures, again, kind of correlate with increased likelihood of having intraoperative changes. This is a recent study from 2024 from GSJ that looked at the causes of the intraoperative neuromonitoring and spinal deformity. This was a systematic review, and again, kind of highlighting the top three specifically are the correction, the osteotomy, and pedicle screw placement were the biggest or the time points during the cases that had the highest amount of intraoperative neuromonitoring changes. So just something to be aware of during these procedures. This was another one that looked at when the alarms occurred in regards to intraoperative monitoring, but interesting also was the rescue intervention successful. And so they found, unsurprisingly, that a lot of the alarms can happen during deformity correction or three-column osteotomies. And in total, about 70% of the alarms could be rescued. And by that, if you address it at the time point within the surgery, that 70% of those signals or of the changes kind of resolved. And so lends to the importance of prompt and immediate addressing, and these can be reversible. They're not always irreversible things that you may see intraoperatively. All right, talking about anesthesia in specific, I think just important for us to be aware as surgeons that these are the different types of anesthesias that can disrupt MEPs and SSEPs. So on the high end are the nitrous, and then going to the low end are the fluoranes, and the lowest being desflurane. IV agents are preferred. So propofol has less an effect. Etomidate and ketamine may actually increase the strength of signals, and opioids fortunately have negligible effects. So when possible, utilizing IV agents is preferable. Paralytics can be good for SSEPs, but obviously disrupt MEPs and EMGs as we discussed. And so again, summarizing some of the significant changes, SSEPs, we have the 50-100 criteria, 50-10 criteria with a greater than 50% drop in amplitude or 10% shift in delayed latency. MEPs, you can either look at the presence or absence, but typically we look at greater than a 65% drop in amplitude from baseline. And then in regards to EMG, we really don't have any guidelines. We usually just look for prolonged high amplitude discharge. All right, so signals go out. What do I do? Easy to kind of go to this mentality, but there have been a number of good studies and checklists that have been established, particularly by the WashU group, that I think are very instrumental in terms of managing these changes. And so you want to start having this differential in your head, right? So what are the technical things, what are the background things, and then what are the physiologic things that could be happening. And when it comes to technical, you can think of, is there a cable that's disconnected? Is there a wire that's been pulled out? When you're talking about background noise, is the fellow using the bovie when they're not supposed to? Is the bed being moved? Is the C-arm bumping? Is the bear hugger on? These are all things that can cause background noise and cause change in signals that could be disrupting the interpretation. And then we think about non-surgical physiologic, so changes in blood pressure. Are they starting to have low hemoglobin or hematocrit? Are they hypothermic? Are they changing the anesthetic? Is the patient positioning changing? And then obviously the surgical changes. Is there a reduction that was performed? And these, fortunately, tend to be focal and with rapid onset. So it's important to identify the change and verbalize the alarm. And I think that's true from the neurophysiologic or neuromonitoring standpoint to the nursing staff in the room to the surgeon. Everyone needs to be in concert and communication with the identified change and what could potentially be done to reverse the change. And so this is kind of just a walkthrough in terms of how you may want to think about it. So you identify the significant change. Is it reproducible? Is there a waveform change? If so, then you're going to think about physiologic changes, which can be common, and non-physiologic changes, which also can be common. And those are quickly and easily reversible using the bovie, blah, blah, blah. Then you can reoptimize. When you get to the physiologic changes, you're thinking about things from maybe the anesthesia perspective and things from the surgical perspective. And so if you have a more generalized systemic change in readings, maybe you're thinking more of the physiologic non-surgical. If it's more focal, then you may be thinking more surgical. But again, that's not set in stone. It can be one or the other two. But again, you just want to be able to think that way and address it. So from the anesthesiologist perspective, it's important to communicate, decrease stop gases to optimize signals, give fluid if you need to, increase the maps if you need to perfuse the brain and the spine, and then blood products if you're having significant blood loss, also increase the temperature. From the surgeon side, again, it's, the top point here is communication. And so communicating with the neurophysiologist, communicating with the rest of the surgical team is exceedingly important. You can adjust and release traction. Steroids in the field, maybe. I don't think that's really utilized that much. A wake-up test can be done, or you can abbreviate the surgery or stage it if you need to. If you're satisfied that you have done everything that can be optimized, that there is no way or no evidence of neurologic compression, there could be a false positive. But again, you want to be exceedingly sure that you have ruled out every other cause before kind of progressing to that point. And again, you don't want to do nothing. You always should investigate and then document. Very, very important. So this was the study I was talking about. This was a multimodal approach from the group from WashU. And I think the really important thing is this checklist here, which I don't know about you guys, but I probably would want to keep this, just to have handy, because in the heat of the moment, you may not be thinking through these things coherently. So it's nice to have maybe a standardized way to go through and try to optimize all these things if there are changes in signal. They kind of reiterate the things that I've been talking about. A couple of things I want to highlight, and Dr. Mundis definitely has highlighted in some of his previous talks, are the artery of Adamkowitz. So did you ligate one of the nerve roots from T10 to T12? That could be a cause of, causing ischemic changes to the anterior spinal artery. And so one way to maybe avoid that is to clamp or clip the nerve for about 5 minutes, including the radicular artery, see if there's any change, and then proceeding with taking the rest of it. And the wake-up test is the gold standard. But I think really importantly, and it might be difficult to see on here, is consultation with a colleague. If you're not sure, ask for help. Don't be afraid to ask for maybe a senior neurophysiologist or an anesthesiologist or one of your colleagues to come help. Especially when it comes to this stuff, we want to be very sure and confident that you're utilizing all the resources at your disposal. And so that includes getting help.
Yeah, all my mentors have always reiterated, just get on the phone, call somebody, and just give you some side input, because you're not thinking right.
Right. So, right. Exactly.
Somebody else can kind of think from outside the box.
Absolutely. Yeah. I think that's kind of one of the dark horse points. And, I wish it was maybe featured a little bit more prominently, but seriously, just getting help and getting another perspective can be really important. Great. So in conclusion, again, we typically take a multimodal approach to intraoperative neuromonitoring. This can both increase the sensitivity and specificity for detecting neurologic injury. Adverse events may closely be more associated with MEPs, but again, there is utility both using SCPs as well as EMGs. And there is maybe that lag time behind MEPs in regards to SSEPs. Now, all changes are irreversible. Again, if you go through that checklist and we talk about some of the literature, you can reverse, problems seen with intraoperative monitoring. So always go after things that that you can. And then thoughtfulness in the differential, think about the technical, the physiologic, non-surgical, the physiologic, surgical, get help if you need. All these things should be kind of going around when you are encountering anything that is related to changes from intraoperative monitoring. That's all I got. Take questions or anyone has anything?
No, that's really well done. Thanks, Yusef.
All right, great. Thank you.
Nice, very nice. Lateral.
Mhm.
Just the way you think about that, it's still a little bit evolving.
Mhm.
You mentioned proximity
Yeah,
versus directionality, both important, but
Right, yeah.
directionality is
Yeah.
more important.
Mhm.
And then, I don't know, I didn't hear it, but the SSEP thing
Mhm.
may be somewhat prognostic. We don't know that for sure, but that's the theory is that, say, SSEPs at the saphenous is a precursor
Right.
for a nosedive of the femoral nerve.
Gotcha.
So we still don't know the optimal way to monitor.
Right.
We still see deficits afterwards,
Mhm.
just like you do with PSOs.
Yeah, yeah.
You don't get any warning. You
Right.
deficits afterwards. So
Right.
still a work in progress.
Mhm.
Important. And then one other thing I wanted to bring up, always important as you go out there, think about the utility of that modality relative to what you're going to do differently. It's obvious in deformity.
Mhm.
It's not terribly obvious with myelopaths,
Mhm.
right?
Mhm.
Because you often get super crappy signals.
Right. Right.
But and some people don't use it at all.
Yeah. Yeah.
What's the problem with that? Then you brought it up at the end. It's not necessarily what you're doing, right?
Right.
It's what anesthesia is doing or what the patient's physiology is doing.
Mhm.
So I still personally think myelopaths are important to monitor because you may need to guide the rest of the team on what to adjust, not necessarily what you're going to do differently.
Mhm.
That's different than deformity, obviously.
Right.
And then don't use it when you're not going to change anything you do.
Yeah.
There's zero rationale to use it for an ACDF.
Mm.
It's not going to change anything you do. You're not going to change blood pressure or anything else. It's not a cord issue.
Mhm.
So if you got a radiculopathy or you're doing a microdisc, you're not going to change what you're doing. You still got to retract the nerve and get the disc out. You know what I mean?
Right. I see.
Just
Yeah.
be thoughtful about what you actually can change
Right.
in the course of treatment
Right.
when you choose to use the modality.
Right. Good point.
Some people just use it for everything
Mhm.
without that thoughtfulness.
Mhm. All right.
Okay.
Great.